Peanut and tree nut allergy are the most common allergens implicated, and there are there are a couple of shellfish, one with egg allergy, but far and away, peanut and tree nut allergy is the most commonly implicated. And importantly, failure to treat properly with epinephrine or lack of epinephrine is related to fatal outcomes. So, when you see your adolescents with significant asthma and peanut allergy, you really got to worry about them, and they're particularly difficult to sort of hammer this point home with, but you got to spend the time. These are the kids who are at risk and that we are particularly worried about. And again, as I talked about in the early part, these are biphasic reactions. So you get early response, which are the typical symptoms. When they present to the emergency room, we're worried about late phase responses, and they need to be watched. They need to get on steroids early on. So treatment of anaphylaxis, immediate treatment's imperative. Epinephrine should be on hand for all of these patients, and they should know how and when to use them. There's no contraindication in an anaphylactic reaction to give an epinephrine. Even if you're 70 years old with coronary heart disease, if you're having an anaphylactic reaction, this is the only thing that's potentially life-saving. If you don't give it promptly, there is an association with fatalities. Intramuscular administration is better than subcutaneous. You get better absorption. And it has to be available at all times. And usually we instruct families to have 2 of them available. Sometimes you treat them, they get better in 10, 15 minutes, the symptoms come back. They live out in the country, not accessible to an ambulance, so they have to have 2 available. So the epinephrine's key. Antihistamine they can also have. The only indication, though, is for cutaneous reactions. And after the initial treatment, they've got to get to an emergency room, and they need to get on steroids, any other treatment they need, vasopressors, whatever emergency treatment they need. And they need to be observed for a minimum of 4 hours. Venom-induced anaphylaxis is a subset. There are about 13 million people in the U.S. With venom allergy. There are about 40 to 100 deaths per year from stinging insect allergy. And what insects cause this? Well, it's the Hymenoptera, so bees, wasps, yellow jackets, hornets. Fire ants is another common one in the southeast U.S., and they're slowly marching northward. You don't get anaphylactic reactions from mosquitoes. You don't get them from other insects. These are really the ones that we're worried about. Large local reactions to stings are common. They're not predictive of progression to anaphylactic reactions. So, again, we get this a lot, large local reactions. There is no particular concern there of progression to an anaphylactic reaction. Anyone who's had a systemic reaction needs to have epinephrine. Again, it's life-saving, and there are fatalities from this. Venom immunotherapy is very effective in these patients. So if patients have had significant reactions, really they need to get venom immunotherapy. What you're doing is you're reversing the underlying problem with the immune system so that if they're exposed, they don't react to it. One of the favorite board questions is what are the criteria for venom immunotherapy? And a child under 16 years of age who's stung and develops diffuse cutaneous reactions, so they're stung on the arm and they develop hives all over, those patients are not candidates for venom immunotherapy. Progression to anaphylaxis is not all that common. If you take someone who's 21 and they have the same reaction, they become a candidate for allergy immunotherapy, and it's just based on the natural history of these things. So really in children, the indication isn't isolated cutaneous reactions. It's other involvement, respiratory involvement, hypotension, other symptoms that puts them in this category. What else causes anaphylaxis or anaphylactoid reactions? So latex is common. Fortunately, we're not using as much of it. Drug reactions are common. It's a long talk, and I'm not going to go through the details, but certainly you get many referrals for antibiotic allergies. Chemotherapeutic agents, there's aspirin sensitivity and nonsteroidal anti-inflammatory drug sensitivity. As we're using more biological agents, things like Remicade, vaccines, we're seeing more reactions, and there are actual large programs being designed to study these reactions and figure out how to assess them and treat them. You can have anaphylactoid reactions to radiocontrast media. These aren't IgE mediated. It's not a contraindication for getting radiocontrast. You can pre-treat with steroids and Benadryl both prior and after infusion. And most patients can get whatever diagnostic testing they need. Exercise can trigger anaphylaxis, so there's exercise-induced urticaria and anaphylaxis. And then there's a subset of idiopathic cases that are particularly frightening with true anaphylactic reactions triggered and unexplained, no identifiable trigger. And some of these patients that are severe need to go on prophylactic regimens with steroids and antihistamines. Question 6, child's born to a couple, both have allergic rhinitis. So both parents have allergic rhinitis. Their first child has atopic dermatitis. What are the odds that their newborn child will develop an allergic disease? It's closest to 20%, 30%, 40%, 50%, or 60%. So 60%. So genetics clearly plays a major role in these disorders. It's not all genetics. Genetics in these disorders in particular gives you a predisposition. Environmental factors are critical. And when we talk about hygiene hypothesis to explain why these things have increased over the past few decades, it's the environmental exposures on top of the underlying genetic predisposition that's critical. And what we're all interested in is preventing allergy. You know, we want to identify these very young children who we know are going to have problems as they get older, particularly with things like significant asthma, and we want to treat them at the youngest ages before they get remodeling in the airways and develop some of these later disorders. How do you predict atopic children at birth? Well, family history certainly plays a big role here. Again, both parents with allergic diseases increases the risk that the child's going to have it. You can